Hello, I am Sophie GEORGIN-LAVIALLE. I'm working in the French National Center of Autoinflammatory Disease and AA Amyloidosis, and I'm going to speak today about what's new in AA amyloidosis in 2020. Here is the different aspects that I will speak about, and I will begin by the background on AA amyloidosis. So, as you may know, amyloidosis is diagnosed by red Congo deposition, and it gives yellow-green birefringence on polarized light, like a green apple. And here is what you can see on a glomerule. On the left side you can see the red Congo coloration, and on the right side you can see SAA staining with an antibody anti-SAA in immunohistochemistry. Amyloidoses are classified as localized or multisystemic, and AA amyloidosis is an acquired multisystemic amyloidosis. And in France, or in France, it is probably nowadays the third cause of amyloidosis, because we think that wild-type TTR amyloidosis is probably the first one with many cases, and AL has the same number of patients. Serum amyloid protein is an inflammatory protein that has about the same kinetic as the C-reactive protein, but the only difference between the two of them is that serum amyloid protein is amyloidogen, whereas CRP is not, and so SAA can give AA deposits, whereas CRP doesn't give any amyloidosis. On this slide you can see a very schematic image of amyloid deposit in the course of chronic inflammatory disease, where chronic inflammation induces elevated SAA concentration, and these SAA high concentration rates in combination with other factors induce amyloid deposit along the vessels. And as kidneys are the second organ after the brain, the most vascularized, maybe that's the reason why it's an organ that is very much touched by AA deposition. Here is the resume of clinical manifestation of AA amyloidosis. Mostly they are non-specific symptoms, sometimes nothing, or sometimes just asthenia, anorexia, nausea, or edema of lower limb in case of nephrotic syndrome. And on the right you can see the specific feature, with the kidney being the most involved organ, with glomerular deposition. And the digestive tract is also very much touched by AA deposition, but sometimes it can be asymptomatic. The liver and the spleen can also be enlarged, and there can be a thyroid goiter, which is quite specific of this type of amyloidosis. Most frequently, patients display proteinuria and or renal failure. Here is a scheme of the main types of amyloidosis, with AL, TTR, and AA, and the main touched organs. As you can see on the right side, kidney is the mostly involved in AA, and also the digestive tract. So the difference between the three main systemic amyloidosis show that in AA there is mostly no heart manifestation and no neurological manifestations. That's different from the other. And the other difference is that in AA amyloidosis you can have a thyroid goiter, which is almost never present in the other types of amyloidosis. How do we confirm the diagnosis in 2020? Just like before, so the diagnostic is histological, and we can see amyloid deposit after a staining by the red Congo coloration. And you can recognize the picture that I showed in the first slide, with amyloid deposition along the vessels on the first one. On the second one it's the birefringence on polarized light. And the staining is an immunochemistry staining with SA antibody, which is a doing very well in immunochemistry. As you can see on the little image, you can see SAA staining on a glomerule. And we always check that there's not deposition of kappa or lambda antibodies. That can be done by immunochemistry, but for kappa and lambda antibodies, they work better in immunofluorescence. In the world, the proteomic or the mass spectrometry analysis to confirm the protein that is mainly in the amyloid deposition can be done. In France, we can do that in Toulouse with Dr. Colomba, and probably soon in the Parisian area. The evolution of the disease depends on the progression of renal disease. So if the patient has terminal kidney failure and has to go under dialysis, the prognostic is more severe, and dialyzed patients have a higher rate of mortality. On the right side of the slide, you can see the extension checkup that we propose in case of AA amyloidosis. We especially think that the renal failure must be checked by creatininemia, glomerular filtration flow rates, and proteinuria and creatinuria. That's the most important. For the other organ involvements, we propose to follow by the clinical symptoms, and the cardiac features are very rare, and we believe it's less than 15% of all AA amyloidosis patients. Most of the patients that have cardiac failure are patients with other risk factors for cardiac insufficiency, such as tobacco, hypertension, obesity, diabetes, and the exam that we propose to do for all AA patients are BNP, troponin, and then electrocardiogram and a transthoracic echography. We don't think it's necessary to perform MRI or scintigraphy, whereas it's necessary in the other amyloidosis type, but not in AA. And we really think it's important to ask for a cardiac expert advice if you doubt about heart involvement in AA amyloidosis, and we have a lot of amyloidosis cardiologists, experts in France. Now we'll speak a little bit about the etiologies of AA. On this slide you can see the main categories of causes, of common ones and less common ones. On the left side, it's very well known the inflammatory disease, such as inflammatory rheumatism, inflammatory bowel disease, and autoinflammatory disease, especially familial Mediterranean fever, because it's the most frequent monogenic autoinflammatory disease, with about 100,000 cases worldwide. On the center of the slide, you can see a chronic infection disease, mainly tuberculosis and bronchiectasis, which are not so rare, especially in France. And on the right side, you can see other situations, such as common variable immunodeficiency, HIV infection, Castleman disease, some inflammatory lymphoma, and inflammatory situations such as Waldenstrom disease or Schneider syndrome. On the left, you can see also the word obesity, so we'll speak a little bit about it. How to deal with a patient when you discover AA amyloidosis? Firstly, always be sure that it's a real amyloidosis, and then you have to type the amyloidosis and be sure it's the real type, because if you think it's AA but it's AL, the patient will not have a chemotherapy, so it has an important impact on the treatment. Then, if you're sure it's AA amyloidosis, you have to check CRP and SAA, are they high or not? And then you have to look for the most frequent etiologies of AA amyloidosis in France, such as chronic rheumatism situation or inflammatory bowel disease. And then you have to check for chronic recurrent infection, such as tuberculosis, bronchiectasis, or osteomyelitis. It's important to take a long time to examine it and ask questions to your patients, especially personal history from his childhood, and familial history, perform a genealogic tree and ask for geographic origin, especially Mediterranean origin in case of familial Mediterranean fever. If you look for auto-inflammatory disease or inflammatory disease, functional symptoms are important to check, such as musculoskeletal, gastrointestinal, and cutaneous. We think that few explorations are necessary based on anamnesis and clinical examination. If the patient displays joint pain, you have to ask for a standard radiography of the joints that are painful, and a little bit of antibodies such as anti-CCP, rheumatoid factor, and anti-nuclear antibodies. If the patient displays digestive symptoms, you can look for inflammatory bowel disease by fecal calprotectin and ask for endoscopy. And then in case of chronic infection or neoplasia, you can ask for a CT scan to look for bronchiectasis, and you can ask for a TEP scan to look for neoplasia or hyperfixative lymph node. After eliminating those frequent causes, you can look for rare causes, especially autoinflammatory disease, and also think about mixed causes which are not so rare, for example, tuberculosis and obesity, or tuberculosis and familial Mediterranean fever, or obesity and osteomyelitis, or obesity and gout. And then, after all this, you will find the optimal treatment according to the cause. Here is a proposition of a checklist for rare inflammatory disease. Always try to find CRP rate in crisis, but actually if the patient has AA amyloidosis, usually it's chronically elevated. Then age of onset of the symptoms, crisis duration, and Mediterranean origin. The family tree will be important to look for dominant transmission or consanguinity or recessive disorder. Then the associated signs that I just talked about, but some specific features are interesting in AA amyloidosis, such as deafness for cryopenopathy and body mass index, if you are expecting that obesity is the etiology. And then some more biological and morphological exploration to look for some specific AA causes, especially monoclonal gammopathy, like Schnitzler or Waldenström, immunodeficiency, to look for common variable immunodeficiency or ADA2 deficiency or HIV, a tumoral syndrome, looking for Hodgkin or non-Hodgkin lymphoma or Castleman disease, and the hemogram and the smear to look for myelodysplasia. If you look for an autoinflammatory disease, the most frequent one is familial Mediterranean fever, because it's the most frequent worldwide. And some other are more rare, but maybe the less rare should be CAPS with NLRP3 mutation. Which patients with autoinflammatory disease can develop an AA amyloidosis? Mostly undiagnosed patients. So if they are not diagnosed, they are not treated, so they have chronic inflammation and they can lead to AA amyloidosis deposit. Also non-compliant patients. That's mostly in familial Mediterranean fever, where they don't take their colchicine, or they say they take it, but they don't. And other associated cause of inflammation leading to inadequate or insufficiently dosed treatment. For example, a patient has a treatment, for example, colchicine in familial Mediterranean fever, 1 milligram per day, but he doesn't have any more abdominal pain, but CRP is never controlled and is still elevated, for example, 40 or 50, and then the patient can develop AA amyloidosis. Now I will speak very quickly about some rare causes that I think that are interesting. Primary immune deficiencies are a cause of AA amyloidosis, especially in common variable immunodeficiency with bronchiectasia. And among these patients, if they don't have immunoglobulin substitution and if they have a long diagnostic wandering, it can induce chronic inflammation. And on the lower side of the slide, you can see what I call a timeline of AA amyloidosis, and you show that in those patients, the disease usually begins early, at 17 years old, but there's a long diagnostic delay to diagnose AA amyloidosis, which is usually diagnosed at 33 years old. And it can also reveal the common variable immunodeficiency and lead to death. So it's a severe complication of AA amyloidosis. Also, Castleman disease, it's a little bit more known that these diseases can induce AA amyloidosis. There are about 40 cases reported between France and the world. What is interesting is that in half cases it's unicentric Castleman disease, and the AA usually reveals the unicentric Castleman disease, which is mostly abdominal. And what is also interesting is that in case of unicentric Castleman disease, the AA treatment is surgical, which is the only surgical treatment in AA amyloidosis. And in case of multicentric Castleman disease, tocilizumab is very efficient. What about obesity? We usually say AA amyloidosis of unknown origin other than obesity. We believe that it's possible multifactorial causes, and maybe genetic exploration should be performed in the future, maybe by exome, maybe by whole genome. That's an explorative pathway, we believe, in AA amyloidosis. And then there's another notion, it's AA of unknown origin, which I write AAX. On the left side you can see work from the British showing that in the 10 last year there's an increased proportion of AAX compared to other AA causes. We believe that you always have to look for common disease such as rheumatoid arthritis or inflammatory bowel disease. Always sequence the 10th exon of Mediterranean fever gene if the patient has Mediterranean origin to look for familial Mediterranean fever. You can perform a TEP scanner, but there's a low contribution usually. You can ask for further genetic analysis, and we believe that the importance is anamnesis and clinical evaluation. Here this woman, she had hematuria revealing AA amyloidosis, and actually she had very painful arms, and she had lupus. Then what about treatment? The principles and objectives are to normalize SAA. So the etiological treatment is very important in order to stop the production of SAA and thus to stop AA deposition. There's symptomatic treatment that can be given. If the patient has chronic kidney disease, it can be hemodialyzed, or it can have kidney graft. And the AA amyloidosis is the first cause of kidney graft for amyloidosis patients, and it's very effective. If the patient displays diarrhea or water, you will propose a symptomatic treatment also. And then the treatment is based on the etiology of the amyloidosis. So I will only show a few slides about this because it's intuitive. For example, in familial Mediterranean fever, when colchicine was given to patients in 1972, it induced a large decrease in the frequency of AA amyloidosis in FMF, because here you can see two studies performed in Turkey, one before and one after the introduction of colchicine in the treatment of familial Mediterranean fever, and the frequency of AA decreased from 28 to 11%, which is very important. Here is the resume about what biotherapy you can use in AA amyloidosis. On the upper side you can see quite frequent disease such as gout, RA, spondyloarthropathy and psoriatic rheumatism, where you can give in gout IL-1 blockers and the other ones IL-6 blockers. In the rare autoinflammatory disease, mostly we can give anti-IL-1 blockers, especially in inflammazomopathy such as familial Mediterranean fever, cryopyrinopathies, TRAP syndrome, Still disease. But if it doesn't work, you can still try the anti-IL-6 treatment, which has been working in at least membrane kinase deficiency and familial Mediterranean fever, and also in soya and Castleman disease. And on the right, I put maybe in DALA2 complicated by AA amyloidosis, you can try anti-TNF. Then I will conclude. So the key messages are as follows. AA amyloidosis is an elimination diagnosis. The rate of SRA does not mean the presence of AA amyloidosis. It means that if you measure SRA and it's elevated, it doesn't mean that your patient has AA amyloidosis. You always have to look for kidney function by creatininemia and proteinuria, and if those are normal, it's not necessary to perform a biopsy. This incidence is decreasing. There's still a long diagnostic delay, as I showed you on the timelines of some specific etiologies of AA. It may also affect older patients nowadays, and the causes are diversifying. In conclusion, anti-inflammatory treatments for AA amyloidosis are very powerful, but the prognosis remains serious, especially if the etiology is infectious, such as bronchiectasia or tuberculosis. We had a few patients with COVID infection and AA amyloidosis. One died, he had a familial Mediterranean fever and kidney insufficiency. The other one are still going well, and one was dialyzed but totally asymptomatic. In conclusion, nephrologists have a central role in AA amyloidosis, but internists, rheumatologists, infectiologists can participate to find the good etiology of the disease. And we think that in this disease we need a good synergy and collaboration and communication between all the doctors in order to really take care of the patient and find the best etiological treatment. I thank you for your attention. We have the French recommendation on AA amyloidosis that are available online at this website, and we published them a few months ago. And we are available if you have any question in the French National Reference Center for AA amyloidosis in Tenon Hospital, Paris. Bye bye.